Hi, good evening, everyone. Pleasure to be back with you all. And what we are going to do today is do the recallers, whatever questions the students could share with me. We are going to discuss those important questions in the INI Cardiology 2021. And the recallers may be again subject to the questions that may not be recalled completely. And even if some of them are missed out or the options are incorrect, the whole idea is to capture most of the concepts that are behind those questions. So I'm going to take you through and the important references which are related to the questions. We could recall with my group of students around 42 questions. If there are more, we'll be more willing to come up with those questions individually. We can discuss it all in the group of the preparations for DocTutorials. And also what was very interesting and what I was happy to see is that a lot of questions are based on the concepts that we have discovered in our videos in the lecture series. Maybe because we have covered it so extensively, there are 62 video lectures that we have covered for different important topics that are very common and frequently asked, and that's why a lot of questions were propping up from the concepts. They may not have the same options, they were not the same from the test series options, but still a lot of them were based on the same concepts. So let's start with the questions, and we can keep on discussing the strategies also along the way. The first question that we could recall and my student shared with me were poor response to CRT are all except. Now this question is answered on page 547 to some extent in Brunwald's textbook of cardiology, that's volume 1. But remember, these are not the options that are given in the classically in the textbook of cardiology. But then if you search in the literature, it clearly shows that atrial fibrillation, RBBB, and inadequate biventricular pacing, not ventricular pacing alone. If that was the option, biventricular pacing, if it's insignificantly present in proportion, then those are. So that by default rules out one of the important options here, which is a complete heart block. So the page 547 clearly mentions the other predictors, which is that the factors proposed as contributing to the non-responder rate associated with CRT include suboptimal LV lead placement, so which goes on to prove that the adequate biventricular pacing is a must, a suboptimal AV and VV triming, which is again the dysynchrony between the atria and the ventricular and the between the posterior wall and the septum, ventricular scarring, so which is basically ischemic etiology, and the heart disease progression. So the very well known predictors are the LBBB patients do better than the RBBB patients with non-ischemic do better than the ischemic patients. So you have a dilated cardiomyopathy is likely to be responding better as compared to patients who are complete heart block, dilated cardiomyopathy with. And complete heart block, though it's a pacing which is going to happen, but it's nowhere mentioned in the literature because atrial fibrillation again would require a lack of atrial kick. So by exclusion, you can believe that the answer for this question is complete heart block. So I'll be open to your suggestions and inputs. You can chat publicly on the live chat. Moving to the best secondary caller question, best prognosis in hypertrophic cardiomyopathy. Now, this is again a question which is you have to go by the prevalences and incidences from the textbook. Page 1606 in Brunwald's textbook of cardiology, it mentions that the non-obstructive hypertrophic cardiomyopathy, the progression disease rate is mentioned as 10%. You can go to page 1606 on the second column, and uncommonly in 10% patients with non-obstructive hypertrophic cardiomyopathy and physiologic experience progression to NYHA class 3 to 4, at which point they may become candidates for transplant, which means only 10% of non-HCM, non-obstructive HCM actually progress. What about pregnancy? So physiologically, we all know that the HCM in pregnancy should be tolerated better. But if you go to pregnancy chapter in Brunwald's textbook of cardiology, it mentions that the worsening in pregnancy is encountered in 23% of the patients. In elderly, again, it's very well mentioned in the same page 1606, where it mentions that the elderly patients actually have MV apparatus anomaly, which actually is a predictor of a poorer outcome. Now that leaves HCM, which is, we assume in this option, an obstructive HCM in young adults. So these patients otherwise, if they have obstructive, would be worse than non-obstructive. So otherwise, if it's not explicitly mentioned, assuming the prevalence rate of progression in terms of the outcomes, you would assume it to be non-obstructive HCM in terms of percentages. But otherwise, this is depends on how the prognosis is defined. If this question is inadequately covered here, in which case it would be say if you're looking at mortality, if you're looking at the heart failure events, or if you're looking at some other events in terms of prognosis, then that needs to be defined in proper fashion. So I think for the current options and current recall, whatever the question they could recall, this probably means that the answer for this question should be non-obstructive hypertrophic cardiomyopathy. If there are any comments or questions, I'll be open to your comments again. Going to question 3, I believe that my students have shared a pulsus bisvariance image, which was a spike and dome pattern. So bisvariance can be of two characteristics. One is spike and dome pattern, and other is non-spike and dome pattern. Both of them in patients with AS with AR, which is moderate AS with severe AR, you can get bisvariance, and the other cause is a recordable bisvariance that you find in hypertrophic cardiomyopathy. So if the picture was of a spike and dome pattern of the pulsus bisvariance, you were dealing with an hypertrophic obstructive cardiomyopathy. But if you had a patient's bisvariance characteristics, which is bifid and systole, of course, but it was not having a spike and dome pattern, that you were dealing with moderate AS with severe AR. Now again, the options that that have been recalled by our students are not including of AS with AR. It mentions only severe AR, LV failure and sepsis, in which case of course hypertrophic cardiomyopathy would become the option. Going to the fourth recall question, which is Alkapa, which is based on congenital heart disease. And I'm thankful to all my students on the group, our group on WhatsApp at DocTutorials, which we have actually been able to collect all these questions, and I thank them individually profusely that they have been able to submit this question. So this question on Alkapa patients with least propensity to develop LV dysfunction. Now this question is not typically mentioned in Brunwald's textbook of cardiology, but if you'll do a search literature, it would show that those patients who have pulmonary hypertension would have lesser propensity of developing LV ischemia. Why? Because if the PA pressure is high, the steal from the coronaries that happens because of the high flow into the pulmonary artery through the low PA pressure would be decreased to huge extent, and hence the positive perfusion of myocardium is preserved. So any condition where there is presence of pulmonary hypertension, in those conditions you will have good amount of myocardial flow preserved with little amount of steal, because in Alkapa what happens is the collaterals are giving the steal of the ischemia because of the collaterals coming from the right coronary through the collaterals into the patients with having collaterals to the RCA that is opening into the PA. So that thing would actually go in favor of causing ischemia. But if your PA pressure is high, so the steal would be a bit lesser, and hence there will be more perfusion to the anterior territory. Yeah, so I'm getting now the options. Sunny is mentioning that the diagram that was given there was that of pure severe AR, and there was no spike and dome pattern. So because I don't have an image, Sunny, so I'm not sure what image you were dealt with. But yes, it's an important feedback that you can get even in mild AS or moderate AS with severe AR apicillus bisvariance. In patients, if you're getting spike and dome, it has to be HOCM. So depending on the image, that's what we need to see. If they were both were equal, then it would be of course moderate AS, mild to moderate AS with severe AR. So Alkapa, as I was coming back to Alkapa, this is the link that I've shared here. If you can go to the link and copy paste and open it, you'll find an interesting article which talks about not only VSD, the option given here was VSD, but if you have a large PDA also, which will give rise to pulmonary hypertension because of left to right shunt, the pH would prevent ischemia of the myocardium because of decreased amount of steal. So the answer to this question is not pulmonary stenosis or code right or unroofed coronary sinus, but answer is any condition with pulmonary hypertension which would happen with a large PDA or a large VSD. Question 5th on this question, I think we had discussed in our question series also, and I'm repeating it again. Two important trials for the diabetes, because you remember there are going to be some questions in metabolic aspects of cardiology. There are 2-3 important chapters in Grunwald's textbook which they try to cover, and these are again now important therapies that are emerging. So emperor preserved and emperor reduced are the two trials with empagliflozin in heart failure. And HFpEF, when you are asked, again the best data, the only data that could actually translate into survival benefit in terms of preserved ejection fraction, whether if you're looking at the combined endpoint, it was SGLT2 inhibitors that did the beta blockers don't do it, spironolactone doesn't do it, ARNIs failed in the Paragon. When you look at the overall outcome, the only subgroup analysis, it was significant. But if you're looking at the combined endpoint, primary endpoint reduction, it was primarily in patients in the emperor reduced trial in patients on SGLT2 therapy. Heart failure with reduced ejection fraction, drugs with improved survival are all except. Now, this is an important question again based on a recent clinical trial, and that's why I tell you that you should be aware of the late breaking trials, which we have tried to cover in some of our sessions. Previously, also there is a video on various important trials in the acute coronary syndrome, and there is another video that I have recorded and it's available on our platform on patients with stable CAD and revasc. So those important late-breaking trials you should be aware of. For example, BHART trial was for beta blockers. ARNI you have Paradigm HF, dapagliflozin you had, DECLARE-TIMI and DAPA-HF trial for heart failure. DECLARE-TIMI was primarily a diabetes management strategy, but again all those trials are important names you should be aware of. ARNI was primarily looking at Paradigm HF, and then Paragon was looking at the preserved ejection fraction. The trial for Vericiguat is Victoria trial, and Victoria trial actually showed decreased need for heart failure hospitalization, but it did not show reduction in mortality, and that's why this is the odd one out. If you look at ARNI, that is the Paradigm HF, ARNI is reduced the incidence of not only heart failure hospitalization and combined endpoints, but it also reduced mortality. Again, beta blockers in heart failure, we very well know it reduces heart mortality, and so does the dapagliflozin. We know from DAPA-HF trial that it reduces independently mortality as a significant outcome. So the answer for these questions was Vericiguat, and the trial which was the Victoria trial. Now, some of my students could not recollect exact values in the question 7, but that doesn't matter. This was a conceptual question. Basically, patient's age was given. Even they could have confused you by mentioning creatinine. They could confuse you by mentioning, say, body mass index, BMI, etc., etc. Don't be misled by them. All that you need to calculate cardiac output is the simple formula of heart rate into stroke volume, and stroke volume is based on the continuity equation, which talks about if there is an orifice, if you can measure the velocity time integral across it and multiply it by the area, the product of that you get is the stroke volume. So what is stroke volume? Is amount of the blood that passes through per cycle multiplied by heart rate is your cardiac output. So how do you estimate the stroke volume per beat? That would be the area of the outflow, or through any area. Suppose you have to calculate, say, regurgitant amount, regurgitant fraction. Again, the same principle applies. So you have the regurgitant orifice multiplied by the velocity time integral. So you measure the Doppler signal, measure the depth and time, the intensity, the duration, and the area curve under the area and the velocity. So this velocity time integral on Doppler signal and the area of that orifice, when you multiply it, you will get the amount of blood that is passing through, which is stroke volume. After correction of the values that are required, they have standardization for it, and that's how it estimates the same. So when you get a stroke volume out of that, you multiply it by heart rate, and that's how you'll get the cardiac output. So if the LVOT diameter was, say, 2, and say the you will have to then calculate the area. So radius will be 1, so area would be 3.14 centimeters square, and then you'll have to velocity time integral, which will be meter per second, multiplied and get a heart rate, and that product will ultimately give you the the cardiac output. So because the values, nobody could share me the exact values for the question, so it doesn't matter. It's a simple mathematics. You multiply, say, heart rate of 70. If LVOT VTI is 1, then it is 1, and area, if diameter is given, is 3. So 3 into 1 into 70, and probably you will get something like 2.1. So something like that you can calculate. The simple formula is heart rate into velocity time integral of the LVOT multiplied by the area. That is the cardiac output. So that's how you can calculate for any given. This question, again, as I said, can be modified. They may put it for the same heart rate. They may mention the regurgitant, mitral regurgitant orifice is this much, and the MR velocity time integral is this much. So again, you have to multiply that area with the velocity time integral of MR, and then when you multiply it by heart rate, you will get the regurgitant volume, the fraction. A fraction would be the the division of the same from the cardiac output. So once you calculate the total cardiac output and then you divide the regurgitant blood upon the cardiac output, you will get the regurgitant fraction. So the same question can be modified accordingly, and this was a simple mathematics question of multiplying three numbers. Now, another question that is recalled is a 25-year-old female, fever, chest discomfort, dyspnea, chest x-ray patch in the right lung midfield. So this probably was looking at Hampton's hump of a pulmonary embolism. That's how the question was interpreted by most of our students. And they were looking at the ECG changes that don't occur in pulmonary embolism. Basically, that was the question. So if you look at on page 1687 in Brunwald, textbook of cardiology, you will see that you can get ST elevation because of the RV load or RV infarction or RV ischemia. All of them can happen, and that's why you can get ST elevation in V1, V2. So it mentions electrocardiogram, the S1QT3T, but the most common, however, is T inversion in V1 to V4. So you can have T inversion, you can have ST elevation, you can, so that, and again, there are atrial flutter, there are incidences, and the literature mentions that sinus tachycardia is the commonest finding. Atrial flutter and fibrillation can also happen, but PR segment elevation or depression is usually a finding of pericardium, not of any other disorder. So PR depression is very rare and it's unlikely to be a case of pulmonary embolism unless there is pericarditis. Again, this question number 9 was not very clearly shared with me, but I believe and assume that which of the following, the question as it is framed, which of the following is the most common cause of death in infancy? So if you're looking at it in that terms, DTGA unoperated 1-year mortality is 90%, but only 30% mortality for the first year. Abstains usually, as you all know, survives and does better because of the fall in the pulmonary vascular resistance, and hence they do better. Option D was not shared with me, but I assume that the other option must not have been that significant, and hence the option that's most significant is hypoplastic left heart, especially if there is aortic atresia, or if there is, in which case the mortality is very, very high in the first month, almost amounting to 90% of the times. So if the question, if you have some other inputs on this question, you can share it in the chat box. Otherwise, I assume that the question was asking about the highest mortality was associated with which of the congenital disorder, and if these were the options that you're shared with, then I think the commonest cause would be hypoplastic left heart syndrome. Question 10, recall, is PA bending. PA bending is usually done. What is PA bending? So what they do is they put a band across the pulmonary artery so that the RV or whichever vessel it is arising from would get trained against a pressure overload so that it doesn't fail when the ventricle is switched over. Now in DTGA, as you know, pulmonary artery is connected to left ventricle and aorta is coming from the RV. So the PA bending, CTGA, again there is an inversion of both the ventricles, and hence again it would not be of much value. It would be much of a value in CCTGA because the RV RA is connected to LV is connected to PA, while the aorta is coming from the RV, and hence that needs to be again thought of in terms of preparing the ventricle. So you prepare the PA bending, dilated cardiomyopathy, usually you don't do PA bending. Otherwise, if there is a VSD, depending on the kind of DTGA you're dealing with, or CCTGA, if there is no pulmonary stenosis, it's assumed that these patients are without any outflow obstruction, in which case to prepare the underlying ventricle, you may have to do a banding. Otherwise, in dilated cardiomyopathy, PA bending is seldom ever done, just for preparing the patient for futuristic surgery. Pullback pressure tracing, Alkapa, so Kathima is mentioning Alkapa is the other option in that question for the survival. So again, Alkapa, the survival won't be that bad as an HLSS. So hypertrophic left heart would not be, if you're Kathima, you're mentioning it for as an option in patients with PA banding. I assume that you're mentioning that as the option for early mortality. So if that is the case, again, HLSS will still hold the ground. For pullback tracing, the best way is you can pick up gradient also in hypertrophic cardiomyopathy, but in HCM, it may not, couple of reasons. The HCM you may not have, firstly, it may be apical variant, secondly, it may be non-obstructive, thirdly, what is more important is to look for the Brunwald-Brockenberg phenomena, not just the pressure pullback, and hence it's the gradient that is present between the aortic valve and the supraaortic chamber and the arch. That is what is the classical of a pullback. So the classical pullback pressure trace, that again we had a spotter. If you go through our lecture series that we had recorded for the spotters, which is easily accessible and freely available right now on YouTube channel of ours, the pullback spotter was that of a supravalvular. So when you do a pullback, you are actually looking at the LV pressure, LVOT pressure, aortic pressure, and also supra-aortic obstructive chamber, and then the aorta. So when you find out these step kind of a pattern, so pullback would classically go in a patient with supravalvular rather than any of these other conditions. Another important, I'm glad that most of our students could recollect all these trials in detail. But again, Ischemia trial, they did not remember, and I assume that it was properly matched. So IMA trial was for the influenza vaccination after MI. It showed improved survival is correct. Actually, this was one of the trials which has actually pushed for class 1A indication for vaccination in patients post-MI and cardiac patients, why they should be vaccinated for flu. So the flu shots are important, and this is the trial, IMA trial, which actually looked at influenza vaccination post-MI. Ischemia trial, I assume the option was given correct because the students could not recall the option matched for the ischemia trial. If any one of you remembers it correctly, you can share. Explorer HCM trial was the trial of mavacamten. Again, this is very well covered in our lecture series in our video on hypertrophic cardiomyopathy. Accord trial, fibrates did not improve survival. They improved in certain subgroups. Of course, it improved lipid profiles to a huge extent. It also was significant in terms of improving surrogate endpoints, but it was not significant in terms of improved survival in diabetic patients. So survival does not change in Accord. Accord was one of the trials which actually failed to establish fibrates as a therapy. Till then, fibrates were pretty much in vogue, and they were very important therapy in terms of management strategies. So that is the incorrectly matched. Accord was a failed trial. Accord actually was another important aspect was such a tight diabetes control versus not so tight control, and it showed that a very strict diabetes control actually led to more CV events, and the reason was probably hypoglycemia triggered CV events. So Accord was one of the trial where the diabetic arm looked at tight control versus not so tight, and the Accord fibrates lipid trial looked at the fibrates, and again it did not show. Again, there is a subgroup study which looked at the TG cutoffs of different values, and they found out that the mortality reduced at certain subgroups but not across the trial. So you cannot accept across the class analysis of Accord that fibrates reduce mortality in the whole cohort. It did not. Question 13, that is from recall, is wrongly matched. Now this is all from lipids. Basically these are all novel therapies that are emerging in lipid management strategies. Evanocumab is basically not a PCSK9 inhibitor. PCSK9 inhibitors are different molecules. Evolucumab, so probably Ivana and Evolu may have confused some of you, but it's Evanocumab. It basically is ANGPLT3 blocker, which allows faster breakdown of fats that leads to high cholesterol. So the mechanism is different. Volanesorsen is basically antisense oligonucleotide apo-C3 RNA. Bempedoic acid is ATP citric lyase, which is ACL inhibitor, and inclisiran is si RNA against PCSK9. So these are the 4 novel therapies which are emerging in lipid management strategy. The 3 mechanisms are correctly matched here, which is volanesorsen, bempedoic acid, and inclisiran, and they have clearly mentioned that antisense oligonucleotide apo-3 cRNA is volanesorsen, bempedoic acid is ACL inhibitor, inclisiran is siRNA against the PCSK9. Evanocumab is ANGPLT3 blocker, not PCSK9 inhibitor. Question 14, recall, was female, post-MI, pericarditis, fever, chest pain, mild cardiac effusion. So basically this was probably pointing towards Dressler syndrome, and what we were looking at the options that may be there. Dresslers can be associated with pleural effusion. It's not that they cannot develop. They usually do develop pericarditis and pericardial effusion, but pleural effusion can happen. Steroids are not mainstay. NSAIDs, if you go through in the pericardial disease chapter, NSAIDs along with colchicine is the preferred in recurrence. You can use steroids, but because in acute MI situation steroids can be detrimental, it is of course seen days to weeks after, and ECG changes may not be diagnostic are correct. So Dressler syndrome, it can be associated with pleural effusion, usually left side. Steroids are not the first line. First line is NSAIDs along with colchicine. Not correctly matched. Now, again, when you look at the patients with the disorders in atrial septal defects, the various atrial septal defects that have been mentioned here clearly. So in this class, we are discussing about sinus venosus ASD, which is associated with PAPVC, which is correct. We have PLSVC, which is the unroofing of the coronary sinus. So that also is correct. The other option that was mentioned was coronary sinus ASD with complete heart block. This is not correct. So persistent left SVC is as present in 63 to 75% of the patient of coronary unroofing coronary sinus. So that's common. PAPVC again is common. Ostium primum ASD is again common, and it's associated with cleft anterior mitral leaflet. And coronary sinus ASD is not associated with CHB. This is very, very rare, and hence this is the incorrect option. Question 16, which of the following associated with conduction system? Again, if the question was about what of the structure is important in doing an ablation, the option may be slightly different. But if you're looking at options, say in terms of what structure is part of the conduction system, then the answer would be moderator band, because it carries the part of right bundle of the AV bundle of the conduction system to the heart, to the anterior papillary muscle, and hence that is the correct option. If you're given a choice between the two, you will have to choose the option as moderator band. Coronary sinus is of value in terms of cannulation. You put a decapolar through CS and then you try to localize the pathway, especially the pathways on the left side, especially in WPW syndrome or in patients with accessory pathway that you need to ablate for an AVRT. So the structure that is important for ablation is CS, but the structure which is part of the conduction system is basically moderator band. drug of choice for atrial fibrillation that was a straightforward question. So drug of choice for atrial fibrillation with heart failure would be amiodarone. This is a classical question. I think there should not have been much of confusion about this. It's classically used in patients with atrial fibrillation with heart failure. So amiodarone is the drug of choice. Next recall was true about brugada. So in brugada, there was some confusion among students which one to choose from between these options. But the easy way to understand this is that the ECG changes are often masked. Whether we are looking at unmasking of the fever, unmasking the thing, or we are looking at what provokes VT. So that was where the confusion was. So ryanodine receptor mutation is of course incorrect because it is SCN5 which is responsible. Same quinidinine can provoke changes was incorrect because it's procainamide and flecainamide which provokes the changes in Brugada syndrome. The confusion was ECG changes are unmasked by fever or ECG provokes VT. If that options are correctly recalled by all of you, in which case the correct answer would be that ECG changes are unmasked by fever, which is correct. So fever can unmask a patient whose previous ECG is normal, and these patients can show signs of Brugada. They manifest the Brugada changes of ECG in patients if they develop fever. So that is correct. So yeah, Kantima is asking, HFpEF is amiodarone contraindicated? This question was with reduced ejection fraction, I assume. But if your question, Kantima, is about amiodarone contraindicated in EF with atrial fibrillation with HFpEF, it's not contraindicated, but then you have better choices to choose from. Because of long term, you don't want other disorders to check in, because amiodarone has a long term issue in terms of its safety profile. It's mentioned the incidence of, say, again, that's a video on amiodarone induced side effects, which I've covered in one of my video series. You can go through it. The problems are multifactorial in the sense that these patients end up either pulmonary fibrosis, hepatotoxicity, corneal deposits, and very importantly, almost 40% have some or the other disorder associated with thyroid. And because thyroid itself is a very important predictor in HFpEF, hence it's to be taken with a pinch of salt. So you would prefer in a patient with HFpEF to cardiovert. And hence the drug of choice in cardioversion we all know is not amiodarone. And hence it's not absolutely contraindicated in HFpEF, but it's not the preferred drug. So I hope I'm clear, Kantima. The drug of choice in patients with HFpEF is not amiodarone. But here, if the question was heart failure generally speaking, then you'll have to choose. If the question was more specific in HFpEF, then probably you can think of something else. So this brings us to ECG changes are unmasked by fever. While ECG provokes VT, doesn't provoke VT, it provokes ECG changes. I'm not sure how correctly you've recalled the options, but I assume these are the correct options. You can correct me in the chat box if the options were different. But what students have shared, and I assume they shared that exercise provokes VT versus ECG changes are unmasked by fever, then the choice is ECG changes are unmasked by the fever. Long-term anticoagulation is not indicated in. Now, again, this question, again, I would wonder if you could recollect properly what they were looking at and how the question was framed. But I assume that they're looking at which is most evidence-based anticoagulation strategy amongst the choices. Our students could recall three options, which is PPD, peripartial cardiomyopathy on bromocriptine, MISC with severe LV dysfunction, and Glenn shunt. See, in Glenn shunt, you need to keep anticoagulation. There is no question about it, to keep it patent, especially in growing children, because of the size inadequacy. LV dysfunction, if you have risk of thromboembolism, then again you'll have to. But in the literature, again, this I've quoted here, PPDCM on bromocriptine, very little evidence available. But the review showed that anticoagulation should be recommended only if PPDCM is EF less than 35 until EF is recovered, as well as for patients treated with bromocriptine. So, I mean, whether the question was long-term or whether you were looking at which of them is least likely to receive, how the question is framed. If they are looking at in terms of long-term, then you'll have to look at these options in terms of the peripartial cardiomyopathy on bromocriptine patients developing EF of less than 35 until EF recovers, as well as patients with PPDCM treated with bromocriptine. So long term it is not. That is what I wanted to share with you. So it's not a long term option in these patients. Clinical description suggestive of HCM on Valsalva. What will happen? Again, this was a simple question. The question was very self-explanatory. As I have mentioned in one of my series also, and there is a video on that. That the simple dictum to remember is all murmurs decrease except HOCM and MVP on Valsalva and standing. So anything basically MVP and HOCM murmur, they become more prominent when the LV cavity becomes smaller. Anything that increases LV cavity size, the obstruction in the prolapse will decrease and the murmur will decrease. Anything that reduces the LV size, the obstruction and prolapse will increase, hence the murmur will increase. So when you do a Valsalva, venous return is decreased, the LV cavity becomes smaller, and because the LV cavity is smaller, there is more obstruction and hence the murmur will increase. So that's the option, which is very self-explanatory in dynamic auscultation. Increased CV risk are all except. So CRP more than 15 would not suggest, because we all know from the various trial, including Jupiter trial, the inclusion was between 3 to 10. If a patient has got CRP more than 10, in which case you will give and treat them with anti-inflammatory, antibiotic, etc., and treat the cause. It represents systemic inflammation, not the inflammation of endothelia. And then repeat their HSCRP. If the HSCRP is, according to various trial, more than 2 or more than 3 but less than 10, not 15, it would not amount to increase risk factor if it's more than 10. So HSCRP more than 15 is not. Lipo-A, of course, is. Ankle brachial pressure index is also a predictor of increased CV risk, but HSCRP, that was the catch. HSCRP extremely high would not come from the vascular endothelium. Very high would come from a systemic inflammation. So that's why HSCRP more than 15 is the wrong option here. Coming to CP versus RCM, I always say this is one of the topics that is always going to hit you questions. This is one chapter you can sure shot get 2 or 3 questions coming from it. Page 1674 from Brunwald textbook of cardiology. That table, as I say, if you can't remember anything, just go through that table. And this is why the option A is incorrect, because the restrictive cardiomyopathy is a disorder of muscle. Hence, the longitudinal contraction, when you're looking at the accord, the myocardium, which is hanging like this, and it is contracting, the muscle, if it is diseased, the longitudinal will be reduced in restrictive cardiomyopathy. And it will have, however, good preserved circumference. So an RCM, you get the speckle tracking. CP, you will get the other way around. And this is again very well clear in the last point of comparison in table 83.7. Speckle tracking, you have normal longitudinal but decreased circumferential restoration on speckle tracking in constructive pericarditis. So option A was incorrect. Rest of the square root can be seen in both, though usually it goes with the constriction. Increased tissue Doppler velocity is a vague term. It depends on what you are looking at. I think this may be more clearly defined rather than how the option is mentioned here. But I assume that the options were reversed here deliberately to get the speckle tracking concept from you. And hence that option, if it was mentioned in this format, this option was the one which was not correct. So you have mitral velocity, respiratory variation. You can go through the table, all the paradoxes, PA pressure, square root. So again, restriction they mentioned, square root is variable, which means it can be present. And that's why this speckle tracking is absolutely the other way around. So hence that is the incorrect option. Again, there is a video that we have done, a complete lecture on stress testing, which we have covered all the important predictors, scores, including how to calculate METs, etc. The not true was cardiac transplant useful in VO2 max of 14, not 16. So it should not, it's not 16, the cutoff is 14, that's why it was incorrect. Heart rate THR, which you call it 220 minus age, is correct. METs is equal to 18 minus 0.15 into age is correct. And 1 METs is equal to any activity which utilizes 3.5 ml per kg per minute of oxygen. So all those 3 options were correct. Cardiac transplant is 14, not 16, and that's why option 23 was incorrect. Cardiomyopathy as a side effect. Again, this I have covered in our one dedicated lecture video on oncologic drugs. And you can go through page 1642. There are important tables to go through that. Table 81.1. Cisplatin doesn't cause. So when you look at this table, cisplatin, carboplatin, and oxaliplatin are associated with arterial vasospasm, hypertension, endothelial dysfunction, but not cardiomyopathy. So the option cardiomyopathy was incorrect. For cisplatin, cyclophosphamide, trastuzumab, and Herceptin, we all know, are associated with cardiomyopathy. Again, the same kind of a question. This time they've looked at the Zumabs. So docetaxel is associated and is at risk of heart failure, but not arrhythmia. Arrhythmia is a side effect primarily of paclitaxel. Bevacizumab is associated with arterial thrombosis and hypertension. Bortezomib with cardiomyopathy. Thalidomide, they've kept increased risk of diabetes, which is again known in some of the studies. However, in our book, they've mentioned in terms of edema, thrombosis, and arrhythmia. So you can have a confusion between C and D, but because docetaxel versus paclitaxel, the biggest advantage they discuss around is arrhythmia. Hence, I think the answer should go by docetaxel. Thalidomide is associated with diabetes. Actually, it is recorded, but though it's not mentioned in our book, so it can confuse you. But I think if I have to bet, I'd bet with option D. Not a finding in young athlete. Now, this is not very classically given in young athlete chapter, but there is a link that I have shared in the video in this slide. And this is an article, very good article by in the JAC, in the Journal of American College of Cardiology in 2019. And this has looked at the ECG of the athletes. The T inversion in V4, V6 is not something that you find. You can find T inversion in V1 to V4, but not V4 to V6. You can have sinus rhythm with heart rate of 40. You can have junctional rhythm of 60. T inversion in V1 to V3, of course, is normal, as I said. Again, there was a lot of confusion on RVMI, all true except. I think there was a lot of confusion by the options that were noted down. Somebody had mentioned steep Y descent. Somebody has shared step X descent. If it was Y, then if the option was given steep Y descent, then you would probably go by pulsus paradoxus. But if the option is given steep X descent, then it's very easy and clear that that's incorrect. You can get steep Y descent, but you don't get steep X descent. X descent is the option. So you can go to page 1153. This is with the RVMI chapter. And on page 1153, it says elevated RV filling pressure, steep right atrial Y descent, early diastolic dependent plateau of square root sign in RV tracing. RV infarction may display Kusamol sign and pulsus paradoxus. In fact, Kusamol in setting of inferior MI is highly predictive of RVMI. So if the recall by some of you was steep Y, then you will have to be a bit confused. But the option, if the option was given was steep X, then there is no confusion. It's never an X which is altered, it's the Y which is altered. So if your option was steep X descent, then it is incorrect. Pulsus paradoxus, Kusamol, and square root all can happen. Going to next question, drugs with TGF beta inhibition action. Now this is ARB. That's how people talk about ARB as the one would work better and maybe more efficacious than ACE inhibitors. The mechanism they propose is that they attenuate the TGF beta signaling by angiotensin receptor blockade and may represent a mechanistically based strategy to modulate pathological progression of mitral valve prolapse, antifibrotic role, even in mitral valve prolapse. So it's coming basically in MVP, it's coming in LV remodeling. So TGF inhibition, that's how theoretically people claim that ARBs do better than ACE inhibitors. So of course, the ARNIs, etc., don't have that mechanism with them. Acute rheumatic fever. Again, if you go through Jones criteria, chorea may involve one half the body is correct. Subcutaneous nodules correlate with carditis is correct. Steroids have no proven role in long term. ASO is supportive evidence. So it's not highly diagnostic. EOS, as you know, it's a supportive evidence. It's not a diagnostic criteria. So this is deliberately framed. If the question is supportive, then probably you will get confused around the other options in terms of, say, steroids in long-term outcomes. As we know, there are meta-analyses which have looked at aspirin versus steroid, and they have shown that there is no significant difference between the two in terms of the long-term outcomes. Of course, they say theoretically, as a notion, you use steroid more for carditis and you use aspirin more for arthritis. But for chorea, subcutaneous nodule correlation, all of them are correct. So I think if it's mentioned that ASO is diagnostic, then it is supportive. Then hence the statement becomes incorrect. So if your recall is not proper for that, then the question may be different. Wrong match, again, most of my students did not share the complete option. So mexiletine for long QT3 is correct. Actually, you can see this again, one of the slides from our own video. Indications of chronic treatment of mexiletine includes in long QT syndrome type 3. So long QT mexiletine may be safer than the drugs that increase QT intervals such as quinidine, and also used in congenital heart and serious ventricular arrhythmias. Tremor, of course, is the side effect. Verapamil for RVOT, those are all correct. Another question was significant stenosis, all are true. The option of QFR, again, people were confused whether QFR is 0.8 or 0.9, where that was given in the option, but I assume that it was mentioned as 0.9. So remember that QFR is again 0.8, its value goes just like the FFR. IFR and RFR go like 0.9, 0.9. FFR and QFR go 0.8, 0.8. MLD area, there is a rule of 4, 5, 6, 7, where the RCA, circumflex, RCA, LAD, left main. These areas should be this much in the imaging. So 4, 5, 6, 7 square is the area that you would expect that these vessels to be centimeter square. So if you're looking at the QFR, then the value was mentioned as 0.9. It was incorrect. The diagnostic accuracy of QFR is 0.8 for predicting of FFR, not 0.9. This is from one of the studies where they looked at the QFR and FFR CT, which showed significant correlation with FFR, and QFR and FFR mismatches can still exist, and it's evolving science as compared to FFR. Diabetic patient, the correct statement based on CARDS trial. CARDS trial clearly showed that irrespective of their lipid cutoff, if you put a patient on 10 milligram of atorvastatin, the events were reduced by 16%. So CARDS trial is one trial which clearly established that statin should be given to all diabetics, and that's why statins for all in more than 50 is correct. Aspirin in more than 50 is not correct in diabetics unless you actually prove that the risk of bleeding is lesser than the benefit. So it cannot be an all-comer statement. A1C target, as I clearly mentioned in the ACCORD trial, very tight control versus not so tight control was actually leading to more event rates. So target below 6.5 is not still the game. The option fourth was not recalled by the students in the group. So based on the three options that you shared, I think statins for all diabetics based on CARDS trial would go as the option. BNP, this is very interesting, and I believe most of you got it correct, is increased in all the following in non-cardiac causes. Remember, we all assume that obesity will increase most of the markers. BNP, it's the other way around. Obesity actually decreases BNP. Obesity leads to decreased BNP mainly by enhancing its clearance through NPRC and nalipressine concentration, and hence increased renal filtration. So obesity also decreases BNP activity, thus decreasing NPRA concentration and BNP signaling pathway. So all other causes, subarachnoid hemorrhage, embolism, renal failure maybe was the fourth option. All of them will have increased BNP levels falsely, or acute MI, but not in case of obesity. Obesity, BNP levels are falsely low. Again, this was interesting take. Again, option D was not shared by most of my students. VKA preferred over NOAC in all except. So in bioprosthetic with AF, you can use it, but there is increased risk of bleeding. So you can use a NOAC in patients with bioprosthetic valve over week, but you can have higher bleeding. Mechanical valve, of course, there is no question. You'll have to use a VKA. There is no question about it. But patients on AKT, the meta-analysis was not significant for looking for an evidence for NOAC. The only problem is that the rifampicin, being an enzyme inducer, alters not only the warfarin levels, but also it will alter and have drug interaction with the NOACs as well. And hence, the issue might be which one of the two to choose. So you may have, okay, the fourth option was APLA, Amit is mentioning. In APLA, of course, in antiphospholipid syndrome, the preferred drug, Amit is correct, is a VKA. So then that fourth option, if it was APLA, then there is no controversy. Antiphospholipid antibody syndrome. So if APLA was the option given here, then there is no question that you will have to prefer it. Mechanical, you have to prefer VKA. Bioprosthetic with AF, as I said, if they develop, there is increased bleeding risk, but you can use it beyond 3 months. So patients with ATT, though there is no significant data available, you would probably still be sticking around to warfarin. So given the current scenario, you would choose patients with ATT as the option of the answer. This was very interesting. PDE5 inhibitor sildenafil useful in. Now this you can go through the chapter on the various causes of pulmonary hypertension. The answer for this, surprisingly, is schistosomiasis. I believe that most of you got it correct. But remember, in COPD, it's the endothelin antagonist. There are multiple lines in Brunwald's textbook Cardiology, which they mention that there are sildenafil failed. There is another trial for tadalafil which failed, and hence COPD is not the correct answer. PVOD, veno-occlusive disease. Actually, when you give pulmonary the sildenafil, patients will actually develop pulmonary because of the dilatory capacity, and there is veno-occlusion. These patients will end up in pulmonary edema. So sildenafil is contraindicated actually in pulmonary veno-occlusive disease. So those two are out. And then post endarterectomy, remember the drug of choice is Riosigua. It's not. Again, if you go through the lines as mentioned in Brunwald's textbook, they mention diuretics and oxygenation as the therapy. So though they are not mentioning any therapy at all for pH management post pulmonary endarterectomy. But assuming that you can give it there, but there are very few cases of schistosomiasis with pH recorded, and most of them actually have looked at treatment with sildenafil. And hence, by the rule of exclusion, because PVOD, pulmonary veno-occlusive disease, is contraindicated, COPD, it failed, endarterectomy, drug of choice is Riosigua, I think you'll have to choose PAH due to schistosomiasis as the cause or as the option here. So again, you can go through the Brunwald textbook. It clearly mentions the other options as a no, no, no. So what is left is this, which is schistosomiasis. Paradoxical embolism, coronary sinus fistula would not cause paradoxical. Platypnea orthodeoxia, you may get sometimes confused because these patients actually get desaturated when they sit up. But that basically means when the patient is having platypnea orthodeoxia means that the shunt is reversing. And hence these patients can develop a paradoxical embolism. So does the patient of PFO, which we all know. Pulmonary AV malformation is already clearly mentioned as another important cause for paradoxical embolism. So what is left out is coronary sinus fistula. It's not a cause. Not a cardioprotective diet is, of course, vegan diet. So DASH diet and Mediterranean diet have been established in various trials. Vegetarian diet actually was established in inter-heart study and inter-stroke study. And in both the studies, the vegans actually did better. And hence, because of that, you would assume that it's a cardioprotective and not the southern. So again, by exclusion, you have southern diet as the non-cardioprotective diet. Early systolic murmur are all except. So any condition where the gradient disappears after half of the flow has happened would have a mid-systolic or early systolic, mid-systolic disappearance, or what you call as early systolic murmur. So in low pressure TR, the pressure of the RA and RV equalizes. So muscular VSD will close. Even large VSD with PH will close, the flow will disappear. So all of them would have early systolic murmur. Other might have been VSD or VSD with PAH, with the other cause. So the option that's left is supravalvular AS. So supravalvular AS, there would be a flow not in the S1 to mid systolic, but it would be classically be either a whole systolic or it may be starting late to mid systolic. So it's not early S1, and that's why it's not the option. Maximum triglyceride reduction, a lot of people were confused. Gemfibrozil versus fenofibrate. So when you look at this study, HHS study, WAHID study, BIP study, field and accord trial, you can see that the percentage triglyceride reduction that is mentioned in HHS by gemfibrozil is 43%. In WAHID, it was 31. In BIP, bezafibrate was 21. In field with fenofibrate was 29. Accord was 22%. And though the inclusions and subgroups were very different, omega, atorvastatin, we all know, are not so potential. So confusion was between fenofibrate and gemfibrozil. The answer is gemfibrozil of in the range of 40%. Remember, 30 to 50% reduction is achieved by fibrates. Obese male diabetic, again, this is a question actually very much of the same kind we had covered in our test series. ACS 6 months back, drug to be added to metformin would be empagliflozin because of empiric outcome. So Monu is saying Brunwald TR with normal PA pressure is given as an option of S1 for early systolic murmur. So it's a early systolic. That's why. So I think the question was except Monu. If we go back to the question on the first S1 to, it's all except. So low pressure TR except. So systolic, as soon as the systole begins, the murmur would begin. So I don't think it's the question because it's except. I think you'll have to choose supravalvular AS as the option. So empiric outcome clearly shows that in diabetics who's post PCI, post ACS, the trial empiric showed that empagliflozin reduces mortality. So the answer is empagliflozin. Frailty index, now this depends on what kind of scores you're looking at. There are multiple scoring system, but hand grips of kgs, I think, is not. Many cognitive scales have been used in some. 5% weight loss is also used by some. So there are various frailty scores that are available. But again, because options are not very clearly mentioned, you can go through them and then confirm the same. Again, there the options were a bit confused for the STMI. Pre-hospital fibrinolysis better than primary PCI. No, it depends on which trial you're looking at. Primary PCI window within 2 hours, again, depending whether you're looking at the whether you've captured the window as what, that onset of pain to PCI or door to needle time or door to balloon time. So the options are not very clear, but I assume that if you're looking at onset to PCI time in first 3 hours, we all know that the lysis is as good as primary PCI. So assuming that they are mentioning primary PCI is better within first 2 hours as compared to lysis, then this option is incorrect. So in first 3 hours, PCI versus lysis are equally effective. So I am assuming that way, and that's why this option is incorrect. Ascending aortic saturation equal to or lower to SVC is a diagnosis of. So option would be TAPVC. So ascending aorta saturation lower or equal to SVC diagnosis would be TAPVC, not TGA, because again, if the question or diagnosis of what are you looking at primarily is the question. So when you have a TGA, the PA saturation, we all know SVC saturation is slightly higher than the IVC. So if you're looking at the TGA scenario, the TGA would have the aorta, ascending aorta coming from the RV, and hence its saturation would be lower to SVC saturation, and hence TAPVC would be the right option. But if you're looking in terms of equalization of all, so the question again is not very clearly recalled by the students. If you were to tell me the exact framing, then I can probably guide you. But if for TAPVC, the answer would be that the saturation in all 4 chambers and the great vessels is almost the same. That is what you call the equalization of saturation. That is classical of TAPVC. So these were the questions that were recalled by most of my students. I think barring a score of, a dozen of them maybe, that's all that is left that you could not recollect. I could take you through a lot of questions here and try to bring out the options that conceptually could help you out in remembering the answers to it. I believe that you would be able to go through our SS medicine also, which will be of great help in understanding and comprehending the preparation for INI. And my best wishes are always there with you, and I'll be back with you with some other sessions on some important question. You can always text me personally, ask me questions that are missing from the recall series here, and there are more questions. I'll be glad to cover them as well. Thank you very much. Stay connected. Keep studying well. My best wishes are always with you, and I'm always there. DocTutorials is always there to help you out in your this study and important time. Take care. Bye-bye.